All right. So the next thing we're going to talk about is drugs that affect your GI system, specifically GI secretions. Now, there's going to be a lot of medications and a lot of classes, but I did highlight and edit these slides to try to put an emphasis on things that I find particularly very important about these drugs, and hopefully it'll help it be easier when you're studying and you're looking at all of this. So, there are drugs that are going to affect different things. They can block the actions of the GI secretions, they can decrease GI secretions, or they can form protective coverings. And they can help prevent the GI from getting any erosions or ulcerations. Now, I made a little summary here, which was not in the slides originally, of what each of these classes of drugs do. So we have histamine 2 agonists, which block hydrochloric acid in the stomach. Okay, it blocks that, which means it helps slow down or remove some of those GI secretions and helps prevent ulceration. Then we have antacids, which decrease gastric acid. We have proton pump inhibitors, which suppress hydrochloric acid. We have gastrointestinal protectants that protect that GI lining. And then we have prostaglandins, which inhibit secretion of gastrin or gastric acid and increase the secretion of mucus, which helps reduce or alleviate some of those symptoms. Okay. So those are the drug classes of most importance. And this is a summary of how different drugs are affected in the lifespan. I would read this over for yourself, which I'm not going to really get into right now because I want to get into the main parts. So this is just an image or an idea of where all of these different drugs work. So as I said, they're all working in the GI system. So always a potential adverse effect is GI problems. Okay. So the first class of drugs that we have are the histamine 2 antagonists or histamine blockers. Now we saw histamine 1s, right? Like diphenhydramine or Benadryl in the respiratory because they have respiratory functions, but we also have histamine blockers or histamine receptors in our stomach. So if we block those histamine receptors, we block hydrochloric acid, and that's really good in helping with those GI problems like GERD or peptic ulcer disease and things like that. So all of these drugs end in tadine: cimetidine, famotidine, nizatine, tinidine, all end in the same ending, okay? Cimetidine causes endocrine or anti-androgenic effects, right? So we might have problems with growth and development and things like that. Famotidine is really good for children. Nizatine is used for renal and hepatic issues because these don't really affect that. So they're pretty good for a person who needs to take this in response to their GERD or a peptic ulcer disease, and they need it because they have also hepatic or kidney problems. So we can give it, it's safe. And retinidine, we don't really use that one anymore. But the main or the most common one is famotidine, and it's approved for children. So histamine 2 blockers block histamine 2 receptors, okay? And they prevent the release of most of that hydrochloric acid or that stomach acid, which is really good in helping these GI problems. Now, these drugs are drug of choice for people who have active duodenal ulcers or gastric ulcers. They could also help treat something called Zollinger-Ellison Syndrome. That is when somebody has an overproduction of gastric acid. So if they have an overproduction of gastric acid, these drugs would be pretty good for that disease because they block gastric acid. And NSAIDs are going to be pretty much in all of these classes as contraindicated because NSAIDs can promote bleeding and GI ulceration. So these drugs can actually help if someone had NSAID-induced ulcerations. Can also be used in GERD, ulcers caused by H. pylori, because GERD and H. pylori cause problems with that gastric acid, and these block gastric acid, and they relieve symptoms of heartburn and indigestion. That's one of the common reasons why someone might take an over-the-counter like famotidine, but they are the drug of choice to treat short-term treatment of active duodenal or gastric ulcers. Now, the thing that I would know is that, right, they're contraindicated in pregnancy because they cross placenta, as most drugs are. And we don't want to give this with hepatic and renal dysfunction. As most drugs, you can't give it because you need the liver and you need the kidneys to help excrete majority of these drugs. Now, as I mentioned before, most drugs cause adverse effects on where they work. So if these drugs work in the GI, adverse effects are GI upset. I feel like that's just a rule of thumb. Wherever they work are also adverse effects in some ways. They also can cause some CNS depression. They can even cause rashes or gynecomastia, which is like the development of breasts in men. And nitizidine and aspirin actually increase the risk. They have drug interact with these, so they aren't very good to keep together. But aspirin specifically increases the risk of ulceration. That's because it's a part of that NSAID family or the salicylate family that causes ulceration. So no good. NSAIDs or aspirin, no good with this class of drugs. But I would remember for adverse effects for sure that they're going to have GI disturbances because these are GI working drugs. Now, this is just a summary of the different signs and symptoms and the way it works that we already talked about. Like, it's a prototype summary, but it's good to read it over if you're trying to review for yourself and try to see how much you remember. And like I said, all of the symptoms here, I remember those GI upsets, I remember the rash, and then it can also potentially cause, right, CNS effects. A lot of the drugs that you're going to see are going to cause GI and CNS effects, but you could start seeing that in between, there's some signs and symptoms that deviate, like in these histamine 2 antagonists or blockers. We might also see cardiac arrhythmias or gynecomastia, which is different than the other classes. Okay, so those are your histamine 2. Like I said, they all end in this tidine ending, and we talked about why they're used, and they're the drug of choice for ulcers. Then we have antacids, which neutralize stomach acid, okay? And drugs that are in this class, and this is, I think, the part that I would focus on the most for your exams, is that sodium bicarbonate is a drug of choice, but if we give this, which is an antacid, it can cause systemic alkalosis, because when you give sodium bicarbonate, it's treating that acidotic environment that the stomach is providing, but it might cause the stomach to become so alkaline that it might cause systemic alkalosis, because a normal pH in the stomach is like 1.5 to 3. So we're giving them this medication and it's alkalizing it. So it's making the pH go higher. So like 5, 6, 7, 8. And if it gets that high, it can cause systemic alkalosis. Calcium carbonate is another form of an antacid, also called Tums, right? And anything calcium related can cause constipation, okay? So you can remember CC, calcium carbonate, can cause constipation, but it's an antacid. It neutralizes stomach acid. Magnesium salts, like milk of magnesia, they are also an antacid, but they can cause diarrhea. So they're usually used as a laxative, but we don't want to give it to someone who has abdominal pain. And ammonium salts are another antacid, or they neutralize stomach acid, but an adverse effect is that they can cause constipation. So these are the main 4 types and what they can cause as a result of giving them. So magnesium salts, like I said, they're more like a laxative, but they can cause an adverse effect of diarrhea. Aluminum salts cause constipation, and that's not good either. Okay, so these, I would know this little section. I think it would really help you, especially on your exams, because that's how I was tested when I had these drugs. They asked me the different types, what they can cause, like what does aluminum salts cause, what does magnesium salts cause. So I would know that for antacids, especially because they're popular over-the-counter drugs. As I said, they neutralize stomach acid. So they're very good for people who have upset stomachs due to an acidic environment, right? Like a GI upset, okay? It could also help relieve symptoms in peptic ulcer and gastritis. So the main point of this is to help relieve sort of symptoms of an upset stomach. Contraindications include allergies, and we want to be cautious with, think about it, right? It's a GI related drug. So if we have GI obstruction, these drugs can't really work the way they should because there's a problem in the GI tract. So if there's a problem in the GI tract, we want to watch out for GI obstruction. These can cause electrolyte imbalances. Why? Think about that sodium bicarbonate, the prototype that I told you about, that can cause systemic alkalosis. Alkalosis is a electrolyte imbalance. So that's a problem. We also want to watch out for pregnancy, lactation, and renal dysfunction. Those are pretty much always givens because pregnancy, you can't really give it anything. Most drugs you can't give, and you always need your kidneys to excrete most of the medications. So I would really want you to know, like I said, those symptoms that I said, aluminum can cause constipation, diarrhea is caused from magnesium. I would know that. I would know those calcium carbonate causes the constipation, and the alkalosis is caused by that sodium bicarbonate. But for the whole class in general, all of these drugs, the problem with antacids or things like Tums is that they can cause rebound acidity. So the more that you use it, even though it's supposed to help neutralize acidity, it can actually make your body more acidic. So it's really not that effective for long-term use. So, it could affect the absorption of other drugs. A really, really important point. If you're using antacids, especially with any other drugs, you should give this drug 1 to 2 hours before giving another drug or 1 to 2 hours after other drugs, because these antacids react with a lot of drugs, so they're not really friendly with other drugs. So rule of thumb here, don't give this in conjunction with other drugs, especially those GI drugs. This is just a rundown of the prototype. Like I said, sodium bicarbonate, you could read into that. But I said the problem that you most particularly see with this is the systemic alkalosis. Okay, that is a problem with that. Any questions so far on the 2 classes of drugs that I went over? No. Okay. So the next thing we have is proton pump inhibitors. Now, this means that we have a proton pump in our stomach area, and they secrete these hydrogen ions, okay? And the hydrogen ions is what allows us to have that gastric or that hydrochloric acid in our stomach, that gastric acid, okay? So if we inhibit the pump, we suppress the secretion of hydrochloric acid in the stomach, therefore reducing that acidic environment. Examples of the drugs all end in prazole. So omeprazole, esomeprazole, lisinoprazole, pantoprazole, you get the idea. Now, something specifically with omeprazole is that it can also cause rebound acidity. That's why we want to give this one 1 hour before meals. That's just something I wanted to point out with that. So, fancy thing that this is saying is that we have hydrogen ions that help make up that hydrochloric acid, and we're suppressing it by interfering with that pump or the pump that produces those hydrogen ions. Now, this drug or this drug class is the drug of choice for that Zollinger-Ellison syndrome that I was telling you about before, when you have too much gastric acid in the stomach. That's why we give these proton pump inhibitors, because they also suppress the gastric acid. So it is a drug of choice for this, whereas those histamine blockers are the drug of choice for short-term duodenal ulcers or gastric ulcers, okay? But all of these drugs can be used for duodenal ulcers, GERD, gastric ulcers, things, because they all work similarly in terms of reducing or blocking gastric acid, except proton pump inhibitors are the drug of choice for this Zollinger-Ellison syndrome, and those histamine blockers are the drug of choice for those ulcers. So, other important points about this medication is that it will take 3 to 4 days to get a full effect. So when you tell this patient, here, you're taking it for your, gastric problems, you might not feel alleviation right away. It's going to take a couple of days. And that's a really important teaching point because they might say, hey, why should I take this medication if it's not working? I took it yesterday and I feel terrible still. Well, it's going to take 4 days. So you got to be patient with it. Other things, allergies, okay, pregnancy. Now, pretty much all of these drugs, like I said, are going to have CNS and GI effects. These like gastric-like drugs, except this one causes upper respiratory tract-like symptoms like fever and cough, and it could even cause increase in bone loss. And that's just because of how it works in the body with the acid. So drug-drug interactions include benzodiazepines, phenytoin, warfarin, especially the benzos, because if these drugs cause CNS effects, I know you haven't learned about anti-anxiety medications yet, but benzodiazepines like lorazepam, they are working in the central nervous system. So if these drugs or these proton pump inhibitors cause CNS effects, I don't want to give them a drug that's going to further increase CNS depression. So that is why we have to be careful with the benzodiazepines. And we have other ones, like I said, ketoconazole, theophylline. Theophylline is just a toxic drug in general. It's one of those respiratory drugs for long-term maintenance. We just don't like it in general. And some anti-retroviral medications, but I would just know that, okay, if proton pump inhibitors work in the CNS, we have to be careful with CNS depressants like benzodiazepines or even alcohol. Prototype, omeprazole, like I said, this is just a summary of everything that we went over, and you can read that whenever you have time. We have GI protectants now, or antipeptic agents, and these protect the stomach lining. So they imagine a Band-Aid. It puts a little Band-Aid on your stomach, and it helps with ulcer healing, okay? It helps heal the ulcers because it prevents that area from injury from the acid. And the drug that we talk about is sucralfate. So, like I said, it treats ulcers by promoting ulcer healing, and it's excreted in the feces. Contraindications include allergies, always think about pregnancy, and we must take this drug on an empty stomach to prevent GI upset, okay? We don't want to take this drug with food. No, it's going to make it worse. As I said, any GI drug is going to have GI effects. So the most common one, though, in this sulfocrate is constipation. Like I said, drug-drug interactions also include aluminum salts because they can lead to renal failure in junction with these drugs because these drugs are also made with aluminum salts. So taking this plus aluminum salts can actually really hurt the kidneys. And drugs like warfarin, digoxin, phenytoin, antibiotics, pretty much kind of like the antacids, they don't work well with a lot of medications. So you should take these 2 hours apart from your major medications. So if I were you, I would take these in the morning as soon as you wake up, and then 2 hours later, after you've ate, like 2 hours later you eat, and then you take all your other medications or whatever else you plan to do. And this is just another summary of the drugs. Then we have prostaglandins. Now, about this drug, what I really want you to know, misoprostol, is that these cross the placenta and they can cause an abortion. Prostaglandins protect the stomach lining by inhibiting gastric acid secretions. That's why we have misoprostol as a prostaglandin. But misoprostol can cause an abortion or a miscarriage. That is what we want to tell them. They should not become pregnant if they're taking this, okay? These can help with ulcerations in patients that have NSAID-induced gastric ulcers. Like I said, NSAIDs can cause GI ulceration. But the most important point is that if you're giving misoprostol, you tell them to use barrier contraceptives. Do not get pregnant because it will cause an abortion or a miscarriage. That is the most important point when it comes to misoprostol, okay? Like I said, it does help with inhibiting gastric acid secretion like pretty much everything else, and it can help with gastric ulcers pretty much like everything else. But the most important point with this is that it has a problem with pregnancy because it can cause abortions and miscarriages. That's what I would know about this drug. Then we have digestive enzymes. Digestive enzymes, we have different ones. We have saliva substitutes and we have pancreolipase substitutes. Now, these are really important because sometimes we have patients that have problems with being able to absorb nutrients, and we give them these substitutes to help with that. Now, for saliva substitutes, these are really important. I know you'll definitely be asked about one of these, if not both. Saliva substitutes contain a lot of electrolytes and they help basically produce saliva. So it makes it easier for that person to swallow, which is really great for someone who had a stroke or a head and neck injury or a TBI or a surgery there, because sometimes post-surgery, a problem is dysphagia. And if we give them this, it can help produce salivation and help them swallow and take in their foods. Pancreatic enzymes are replacement enzymes. So the pancreas is very important in helping your body absorb a lot of fats, proteins, and carbohydrates. However, patients with cystic fibrosis, duct problems, or pancreatic disease can't do that, especially our cystic fibrosis patients. So that means that we give these pancreatic enzymes to them to help absorb fats, because cystic fibrosis is a respiratory-like complication, but it also affects the lungs, the GI, and respiratory tracts, and it causes malabsorption. That's why we see the use of pancreatic enzymes in someone with cystic fibrosis. Now, like I said, these are all replacement therapies. They're substitutes to help for things that they are lacking in. So with saliva substitutes, the problem is cardiac and renal. Can cause hypertension, heart failure, and renal failure. Pancreatic substitutes can cause problems with pregnant women, so we keep them away from people who are pregnant. In terms of adverse effects, like I said about the saliva substitutes, they work on those electrolytes, so they can have problems with electrolyte absorption. So they can cause increased levels of magnesium, sodium, and potassium levels. So for these patients on saliva substitutes, we really want to monitor their serum electrolytes. For pancreatic enzymes, they can cause GI irritation, nausea, abdominal cramps, diarrhea. So you usually take these with food. And yeah, so that's pretty much it with those drugs. Is there any questions regarding any of the drug classes that we went over? No? Okay. So I'm going to go into drugs that affect gastrointestinal motility or laxatives and antidiarrheals. What I want you to know more or less for these drugs is not as much all of the adverse effects and things like that. It's just more or less recognizing which ones are laxatives, which ones are stool softeners, and what they do, okay? So sometimes problems that we have, or one of the most common problems we have is constipation, right? A lot of people get constipated and they take laxatives. Or a lot of people have diarrhea from an upset stomach or getting sick, and we need to treat those things because diarrhea can cause electrolyte imbalances, okay? So we have different medications that work in those different places. Now, this is a summary of all the drugs like laxatives and antidiarrheals that we can use, but I just wanted to point out that loperamide is an antidiarrheal drug of choice for children. So, laxatives we use for short-term relief of constipation to help prevent that straining and help them get rid of that stuff in their body, okay? However, the problem with laxatives is that you overuse them, they can lead to constipation and make it worse, okay? So they're not ideal for long-term use and they're really a last choice. You want them to do interventions like increase in fiber, increase in exercise, and increase in fluids before we even try giving a laxative. But if we do, we have different types. This is where I'd start knowing which ones are what types of laxatives. So we all know these are laxatives. So if you're able to recognize what is a laxative, you know that it's used to treat constipation. Boom, you already know what these drugs do. Now you just have to recognize which ones are what. So stimulants, they chemically irritate the lining of the GI tract to help get rid of the bowel movements. And an example is Bisacodyl. We have bulk forming agents, which cause fecal matter to increase in terms of like, they kind of make it like bulky. So when the fecal matter gets in that state, it's easier to slide it out. We also have osmotic laxatives, which pull water into the GI tract. So it kind of makes it more liquidy and it gets rid of the poop. And an example is milk of magnesia. And then we have lubricants. Lubricants sort of line the intestine, make it slippery so the poop can slide out. And an example is docusate sodium. So, as I said, we have chemical stimulants. And what they do is they stimulate the intestinal motility and they increase the amount of water and electrolytes in the intestinal lumen, which helps you poop it out. So we have bisacodyl, castor oil, which is the prototype, and senna. Those are the examples of chemical stimulants. I would simply know which ones are chemical stimulants. They're all used for constipation, okay? So we don't need to go into why they're being used. Allergies, we never want to give that. Abdominal disorders, right? If they have fecal impaction or fecal obstruction, we're not going to be giving these. These are not going to work. So GI problems, not good. Castor oil, particularly not good in pregnancy. I always caution when people are pregnancy, but I would focus more with these laxatives on which ones or what type of laxative. Is it a chemical? Which type is it? Okay, that's what I would focus on. Adverse effects, I've already mentioned several times. All of these GI drugs pretty much cause GI upset and CNS problems. Now, castor oil, something that does specifically is that it blocks absorptions of fats. So that can lead to malnutrition. That is the problem with castor oil. But otherwise, the general for the chemical stimulants like senna, bisacodyl, and castor oil, we want to watch out for GI upset and CNS problems. Then we have that bulk forming laxatives. They're another type of laxatives that cause the fecal matter to increase in bulk. This increases the motility of the GI tract by increasing the size of the fecal matter to help push it out. And it really relies on water to form like a gel that helps soften and remove the poop. So examples is Phyllium, polycarbonate, and methylcellulose. But I would particularly remember this one. They all treat constipation, but these can also treat patients who have problems with IBS or diverticulose. I'm sorry, I can't say that word right now. It's just not coming out. But they can help treat with those disorders. They act pretty quickly. Contraindications, anything that has to do with intestinal obstruction, intestinal problems, abdominal disorders, all of these laxative working and antidiarrheals, if they have an abdominal disorder, we're not giving them, okay? That's just a rule of thumb. Adverse effects, once again, GI problems, CNS problems. Everything with these GI drugs seems to repeat in terms of adverse effects. There's just slight differences in between certain classes. Patient education for these, the most important part about these bulk forming laxative like Valium is that take with plenty of water because these drugs work by using water to form a gel to help get the poop out. So they must drink lots and lots of water. Adverse effects are minimal, but they can cause esophageal obstruction, which means they could have a problem with breathing. So we got to watch out for that too. But okay, so that's, like I said, bulk forming laxatives. The prototype is Phyllium, and this is just a summary. We have osmotic laxative, which basically help pull stuff like water and solutes into that GI tract and stimulate GI intestinal motility. Now, most of them start with magnesium, these osmotic laxatives, so that's a good way to remember it. But I would say the most important ones would be magnesium hydroxide or milk of magnesia and polyethylene glycol, which is Miralax, another commonly used one in the hospitals, okay? So I remember most of them start with magnesium for osmotics, but the most prominent two are magnesium hydroxide and polyethylene glycol. or Miralax. So, as I said, we draw more water into the GI tract to stimulate GI motility, okay? I would know pretty much with these laxatives, like I said, how they work, examples of them, and keep it more at that, because the adverse effects and everything is pretty much going to be the same. But I think most of the questions that you're going to get is going to be to how to identify which ones are which. Is it a laxative? What kind of laxative is it? Okay. And all laxatives do is treat constipation. But these osmotic laxatives, something that they do a little different, is they help treat with poisons. Okay. So, something also to tell patient education with these osmotic laxatives like milk of magnesium or Miralax is that they take 1 to 2 hours to work. Now, once again, all contraindications for all of these laxatives include problems with the GI. So maybe a surgery, fecal impaction, intestinal obstruction, problems with the GI. No for most of these. Cautions. The lactulose can affect diabetes or sugar levels. Like magnesiums can cause renal insufficiency, and the polyethyl glycol can affect patients who have a history of seizures. I wouldn't get much into it, like I said, more or less with most of these drugs, just knowing how to identify them and what they're used for, because most of them are used for constipation, why they're used. Pretty much all of them cause GI effects and CNS effects. So there's not much that you need to memorize in terms of just knowing which ones are where. So once again, CNS effects, GI effects, same thing, okay? Drug-drug interactions, though, for those magnesium salts is that they could affect those neuromuscular junction blockers. But I don't think they'll ask you that yet because you haven't learned about those drugs yet. This is just an example of the prototype osmotic laxative, pretty much everything that we spoke about already. Then we have, outside of laxatives and things like that, we also have another type of laxative that we can use, but it works differently because it's a lubricant. It kind of forms that slippery coat, right? And it's very beneficial to patients who have hemorrhoids. Now, docusate or Colace, one of the most prominent ones, glycerin, mineral oil, those are examples of lubricants. Like I said, I would know how to identify these. Docusate basically works on the intestines. Glycerin kind of works on the rectum without really having any systemic effects. And mineral oil forms a slippery coat on the intestinal tract. What they're used for, all of them are used for constipation. And these can also remove poisons, but they can also be adjunct in something called anti-helminic, which are basically like sometimes you get worms. Like you might get an infection where a worm gets into your GI tract. So anti-helminic means anti-worm. So these can be used in junction to people having bowel problems if they got an exposure to a worm. Okay, so like I said, I would really know these, what they do, how they work. They're all excreted in the feces. The whole point of all of these is to help you poop. Once again, cautions or problems, abdominal disorders, and pregnancy. Pregnancy is for everything. Once again, we have GI effects, CNS effects, but specifically with mineral oil, we might see leakage and staining. And another problem with mineral oil is that it can affect the absorption of fat-soluble vitamins like A, D, E, and K. That's another problem. Prototype docusate, this is just a summary, okay? Now, we have another class of drugs that can treat constipation in specific situations. So, opioids. I know we haven't learned opioids yet, or you haven't been taught them fully, but you might have heard a lot about them in med-surg and other sections. So, opioids, right, can cause like morphine can cause respiratory depression, sedation, urinary tension, but it can also cause constipation. So these drugs are used to treat constipation induced by opioids. So we have aviamapan, methylnextrioxine. I don't know how to say any of these, but I would recognize these. And maybe a cute little mnemonic that might help might be remember MAN, because there's MAN. They're all the drugs. One is methylbromide, avalomelpan, or naloxone. Like I said, I'm so sorry. I'm probably butchering these names so much, but maybe the mnemonic MAN might help you remember these opioid agonists. So they block the effects of opioids in the GI tract, which helps maintain normal GI motility or helps you go to the bathroom. Like I said, it's used to treat opioid-induced constipation. And alvomopan hastens time for the GI tract to recover following surgeries. So sometimes when we have a surgery where they have a partial bowel resection, these can help increase the time so that they have faster GI recovery than they would using other medications post-surgery. So everything but alvomopan is metabolized in the liver. These are metabolized in the GI tract, but pretty much all of these are excreted in the feces, right? Because it's all the point of this is to treat constipation, to help you go to the bathroom. Okay. So problems would be hepatic or renal impairment in pregnancy, always. Once again, GI issues being an adverse effect, like abdominal pain, diarrhea, nausea, vomiting, always there. Okay. And if they have abdominal pain, we really want to watch out for potential GI proliferation or ulceration. Okay. And yeah, that's pretty much it for those opioids. I would just pretty much be able to recognize them and know that they are used to treat opioid-induced constipation. Now, gastrointestinal stimulants like metoclopramide actually stimulates that parasympathetic rest and digest that help you poop. But Reglan, some of you might know, is also an antiemetic because it also works to help alleviate nausea and vomiting. So an important point about this drug is that it helps you poop, so it's kind of like a laxative, and it helps prevent nausea and vomiting. So like I said, it stimulates parasympathetic, that rest and digest. So we have more GI secretions and motility. We can poop better. Okay? So it's rapidly absorbed. Contraindications include allergy or any sort of GI obstruction. You kind of starting to see a pattern of contraindications, no GI problems if you're giving GI drugs because this is how they work. And this drug crosses the placenta, so we don't want to give it to pregnant people, okay? Adverse effects, once again, GI problems and CNS. And the CNS part of it is because of the fact that in order to control nausea and vomiting, they have receptors in the brain. The brain is where we have those nausea and vomiting receptors. So that's why we get a CNS effect like dizziness, okay? And drug-drug interactions include alcohol or CNS sedative drugs like benzodiazepines, antipsychotics, MAIOs, monoamine oxidase inhibitors, which are antidepressants. All of these cross that CNS, so we don't want to give this patient any CNS depressants or CNS acting drugs because this medication, Reglan or metoclopramide, causes works in the CNS and can cause CNS depression on its own. And I would know that for Reglan, it's used to prevent nausea and vomiting and remove GI content. So it has a duality or dual effect. Any questions? No. Okay. So the next thing, as I said, stop me if you have any questions. I don't mind. So the next thing we have is antidiarrheals. So these block the stimulation of the GI tract, whereas all those other drugs help stimulate the GI tract. We're trying to do the opposite here. Now, some common ones, loperamide, Imodium, opium derivatives like paregoric or bismuth subsolate or Pepto-Bismol, very common ones. And those are the ones that I would really know in terms of antidiarrheals. Now, anticholinergic medications, right, can also be antidiarrheals because anticholinergic means anti-slud. And if you remember, slud means salivation, lacrimation, urination, digestion, defecation. It helps block your body from pooping, which can help in preventing or fixing things like diarrhea. So, as I said, we have different ones. We have Pepto-Bismol or bismuth subsalicylate, and they actually work on the lining of the GI tract. We have loperamide, which works more on the muscles of the GI tract, and this one has no CNS penetration, really good. Opioid derivatives, right, like the paragoric, they act on the CNS receptors and they cause GI spasms and slowing, so they help stop peristalsis. And crofelemer blocks specific chloride channels, leading to less water and helping with stopping that diarrhea. That's how all of these drugs work. So as I said, they help with diarrhea, okay? And they can help with traveler's diarrhea when you go somewhere. With bismuth, it helps also with diarrhea and GI symptoms associated with viral infection. A lot of times they say, take your Pepto-Bismol if you have a, stomach bug. And then we have crofelemer. I don't know how to say that. But it can also give relief to non-infectious diarrhea in adults who are on antiretrovirals, like given to patients who have HIV and AIDS. But like I said, non-infectious diarrhea. So if they have like HIV and AIDS and they're taking these antiretrovirals and they're getting diarrhea, then we can give this specific drug for that. Contraindications, allergies, pregnancy, history of GI obstruction. I feel like this just repeats endlessly. So you will know the contraindications and precautions of all the drugs because everything just repeats. Adverse effects of antidiarrheals can actually end up causing constipation if you take too many, right? If you keep preventing yourself from going to the bathroom, you might not really be able to go. Abdominal distension, another popular one, and dry mouth. Now, with Pepto-Bismol, you see how it says bismuth salicylate. Now, salicylate, right, is aspirin, and they're a part of those drugs that can also cause GI ulceration, but it can cause salicylate toxicity because it's a part of that family. And salicylate toxicity, one of the common symptoms or signs that they have salicylate toxicity is tinitis. For the opium derivatives, right, opioid can cause respiratory depression, like the paragoric, that one. Prototype, loperamide, and like I said, this one is predominantly used in children. It's safe to use in children as an antidiarrheal. Now we have irritable bowel syndrome and chronic constipation drugs. A lot of those drugs that we talked about before were used for acute or chronic, but these are going to be specifically to treat either chronic or IBS, irritable bowel syndrome, which is like an inflammation of the bowels, which cause bouts of diarrhea, constipation, bloating, nausea, and things like that. Okay, so drugs to treat IBS are all of these. I would recognize them. They sadly don't have any common endings like the other GI drugs that we spoke about before, but I would recognize them to know because they might easily ask you which of the following drugs can treat IBS. And I would know that purclopride is the drug that you use to treat chronic constipation. It is the drug of choice to treat chronic constipation. Now, for all of these drugs, pretty much they work in different areas, so they're not all acting on the same receptors. That's also why they all have sort of different endings. So if I were you, I would take time to read these over and know them for your exam because I know they were on mine. So Olocitron, they are anti-inflammatory by blocking some of those serotonin histamine receptors, and they prevent severe diarrhea in IBS. We have Illuxidilline, which is an opioid receptor agonist. So remember, it works on some of those opioid-like things, and they helps with patients with IBS with diarrhea. We also have Lupristone, which is a local acting chloride channel activator, which is just a fancy way of saying it works in these chloride channels, and that helps with alleviating constipation or chronic constipation associated with anything, IBS, opioids, and things like that. And then we have proclopride and tegaserode, which are selective serotonin type 4 receptor agonists. They treat chronic constipation. And tegaserode treats females who are younger than 65 who suffer from constipation with IBS. Linaclotide or peglogenatide, They also treat chronic constipation and constipation with IBS. So all of these, I would just be able to recognize them, recognize that they work for IBS and chronic constipation, except with the exception of this one, treating just severe diarrhea with IBS. And I would remember that would take us a road that it works. It's good for females who are younger than 65 who suffer from chronic constipation due to IBS. Once again, allergies, GI obstruction, pregnancy are all problems and contraindications and issues that we want to watch out for when we give GI drugs. GI symptoms cause any drug that works in the GI is going to cause GI symptoms like nausea, vomiting, diarrhea, constipation, all of that stuff. Okay. And like I said, some of these have different adverse effects that you look at on your own. I personally don't remember being tested too much on this, so I think being able to recognize you reading it over a couple of times would be good in terms for your quiz, because there are more important GI drugs in the system that they're going to ask more about, like the PPIs and the histamine antagonists. Those are more predominantly asked. Okay, so I would review these. I wouldn't spend too much time heavily like trying to look at these drugs. Any questions before I go into the antiemetics? No. Okay. So, antiemetics, the last type of drugs we're talking about. We talked about a lot of different things today. Nausea and vomiting has receptors, like I said, in the brain. So all of these receptors are focusing on the brain. That's going to be very, very important. We have different types for managing nausea and vomiting. We have emetics, which induce vomiting at those brain receptors, and we have antiemetics that prevent nausea and vomiting and work on those receptors in the brain. Like I said, I would read these over. I am going to mention a drug that is specifically good for children, which is promethazine. But just as a visual, if you look really closely, you're going to see these drugs are all working in different receptors of the brain, which means we all have potential, probably with these adverse effects, CNS effects, right? Because they're all working in the brain. They're all working. And some of those anticholinergic antiemetics include glucosine, cyclizine, meclizine. You see how they all end in zine? Anticholinergics that end in zine that are antiemetics. So we have different classes. We have phenothiazines, non-phenothiazines, serotonin 5 receptor blockers, substance P neurokinin 1 receptor antagonists, and we have a miscellaneous group. The phenothiazines, these are all antiemetics. They all end in mazine, chlorpromazine, pyrifenazine, prochlorperazine, methazine, promethazine. This one, very good for children. So that's the one we want to use for children. We could also use prochlorperazine for children. They're both safe for children. Now, the thing is with these drugs is that these phenothiazines, as that some of them, like chlorpromazine, is also an atypical antipsychotic. So even though it's an antiemetic, it's also an antipsychotic. So since some of these are in this antipsychotic class, you're going to have to watch out for something called extrapyramidal symptoms, or EPS. And I'm not going to get too much into that, but they cause slowed reflexes. It's a very bad adverse effect of antipsychotics. So for this class, a particular adverse effect that we're going to want to watch out for is EPS. So these, long story short, they cause stimulation and they change the responsiveness of the stimulation of those receptors in the medulla or the brain, and they basically cause you to stop vomiting, okay? They pretty much work as dopamine agonists. They work on those dopamine receptors, okay? But promethazine is also a histamine receptor blocker while having dopamine agonist effects. Goal, even if you can't remember all that, I would just know these drugs that end in azine are used to treat nausea and vomiting, to prevent nausea and vomiting, okay? They're antiemetics, but they cross the placenta and enter the milk, which means watch out for lactating and pregnant women, okay? The thing is, contraindications, brain damage, CNS depression. Why? Because all of these drugs work in the CNS. So I'm not going to give them a drug that works in the CNS because, or if they had a problem with the CNS, why would I want to give them a drug that works centrally in the brain and they have brain damage? It's not going to work the way we think. It can cause labile blood pressure changes, labile meaning changing. So it can cause hypotension and hypertension. And like I said, rule of thumb, pregnancy and lactation, never really want to give it. Can cause liver problems. So we have to watch out for liver dysfunction if we want to give patients these drugs, okay? And once again, works in the CNS. So an adverse effect, CNS changes, drowsiness, dizziness, weakness, tremors, headache, hypotension, extrapyramidal symptoms, like I said, because some of these are antipsychotics, and they cause anti-slud. So if you know salivation, lacrimation, urination, defecation, digestion, you're in good hands because that is anticholinergic side effects, but these also cause anticholinergic-like adverse effects. So it's good to know anti-slud. That's how I think about the word cholinergic. Is it cholinergic, meaning it works on slud, or is it anticholinergic and causes anti-slud? Once again, since they work in the brain, no CNS depressants. I feel like you're starting to see a repetition of a lot of different things. Like I said, this is just a summary of the prototype. So we have non-benzodiazepines. So these do not work the way the other ones work. They don't work in the CNS the same way those other drugs. They block those dopamine receptors in the brain instead of agonizing them. So remember, metoclopramide we talk about is a GI stimulant, but it also causes prevention of nausea and vomiting. Okay, so that's something that we see with this type of drug. So it works by blocking those dopamine receptors and making the GI cells more sensitive to acetylcholine, which helps with preventing nausea and vomiting. Okay? Adverse effects, because it does block dopamine receptors in the brain, CNS problems, dizziness, drowsiness, but I would just remember from metoclopramide that it has a GI effect, meaning it can make you go to the bathroom, but it also affects nausea and vomiting by preventing you to vomit. Now, we have serotonin receptor blockers. The most commonly asked one is ondansetron. I don't know how to say it, but it's commonly called Zofran, and it's approved for chemotherapy or anesthesia-induced nausea and vomiting. Now, the problem with this is that it can cause QT elongation, or it can cause problems in the EKG. So with these drugs, we really want to monitor for EKG changes, okay? So like I said, they block serotonin receptors in the brain. So automatically adverse effect CNS, okay? So it helps treat nausea and vomiting related to chemotherapy treatment, anesthesia treatment, or radiation treatment, okay? But it's mainly used for chemotherapy treatment to prevent that nausea and vomiting in those patients. Like I said, it can cause a long QT. So we want to monitor those EKGs, and it can lead to something called torsades de pointe, which is basically a really crazy looking EKG, and it's very deadly. We don't want to give this to patients who are pregnant, and it can also cause electrolyte abnormalities, so we really have to be careful. But like I said, ondansetron or Zofran is the most commonly caused one. Once again, a CNS acting drug, which means CNS adverse effects, okay? We could also get pain because it could be an injection. So we might get pain at the injection site, like a rash and things like that. It can cause hypotensive effects, but the main thing is that it can cause prolongation of the QT interval. Okay. And this is just an example of the rundown of it. Like I said, headache, dizziness, drowsiness, all of those CNS effects. It can also cause something called myalgia, which I think is muscle weakness, but I would have to double check, and you'd have to double check that for me. Another class of drugs that are antiemetics is something called substance P/neurokinin 1 receptor antagonist. Anything that ends in pitant, aperipitant, fosapitant, rolapitant, they all cause reduction of nausea and vomiting, and these are used as antiemetics, okay? So that's what it's really good for. And these class of drugs can be identified because they end in this pitant ending. So use for nausea and vomiting, but they cause crossover in the placenta, so we can't give this to our pregnant people. No pregnant people, cautions in that, cautions in allergies, GI effects, these can cause GI effects. And what I would really know is that these can cause those blood labs to change. So it can affect our white blood cells and our red blood cells. So we can have neutropenia, anemia, and leukopenia, okay, which is a reduction of all of your white blood cells. So we must monitor complete blood cell counts with these patients, okay? And we might have to put them on neutropenic precautions, which is something I'll be talking about in your anemia med-surg like lecture. But neutropenic precautions include things like no fresh flowers, no fresh fruits, no visitors, things like that to reduce infections. Drug-drug interactions for any of these patent ending drugs is pimozide, warfarin, and hormonal contraceptives. So no birth control, okay? Now, miscellaneous agents are just a couple of different drugs that I would point out for, okay? So we have dexamethasone or glucocorticosteroids. They can work as antiemetics, but we don't really know why. I really wouldn't focus on that, but it might be good for you to know. Diphenhydrate, hydroxys, meclizine. Meclizine is one of the anticholinergic drugs, the ones that end in zine. They can be used for motion sickness, and meclizine is recommended for patients who have inner ear problems and have motion sickness. Marijuana can also be used to treat nausea and vomiting associated with chemotherapy. Scopolamine is an anticholinergic drug, blocks that muscarinic receptors like the meclizine. So anticholinergic means we're looking out for anti-SLUD, so anti-salivation, anti-lacrimation, anti-urination, anti-defecation, anti-digestion, okay? But scopolamine is mainly used for motion sickness. And yeah, for these different types of miscellaneous drugs, we're mainly concerned with pregnancy, CNS suppressing agents, because they all work in the brain, nervous system, cholinergic drugs, parasympathetic nervous system. They're all working on the nervous system, no CNS suppressing agents, and watch out for photosensitivity. All right, I'm done with this. I'm going to stop recording.